you, and thanks for the invite. For dramatic effect here, I picked up a respiratory something last week. It is not influenza, but I have a little bit of a cough, so I'm not going to force my voice. Can everybody hear all right? Okay. Fortunately, I'm the 6-foot exclusion zone. Well, what I thought I would do when I was asked to give this talk, not sure of the audience, we're going to talk a lot about, and I have to be careful in how I call this, 2009 H1N1, and hopefully the S word won't slip out here. We're careful with the nomenclature here, and technically it isn't swine flu, but we'll talk a little about that. What I thought I'd do, we're going to talk plenty about 2009 H1N1, but I want to go back to last February, which was a much simpler time in our lives when we were just dealing with seasonal influenza and planning for pandemic influenza. And what I want to start there is to make sure everybody is on the same level as far as the influenza epidemics we deal with on a day-to-day basis and the concerns we've had with pandemic influenza for the better part of a half century. And really there are a lot of similarities as I go through that path, and I'll point out these as I go along. And then toward the end of the talk, we'll really get to some of the specific issues surrounding 2009 H1. Did we plan for the right thing? Did the planning go, or has the response gone as the planning thought it would, and so on. To get started, I'm a virologist, and I have to subject you to some virology. But I think it's important because as 2009 H1 has evolved in the context of seasonal influenza, a lot of terminology and nomenclature has been thrown out there, and I'd kind of like to make sure everybody understands where it came from. The points I want to make on this slide, first of all, refer to the cartoon, and there's two key features of influenza that I'll touch on as we go through the talk. The first, it's a virus whose genetic material is contained in 8 discrete segments, each of which codes for a part of the progeny virus after it's infected the host. And it's important to know that it's segmented for the reason that when you get two unrelated viruses, two unrelated type A viruses, and infecting the same host, you can often have an intermixing of the genetic components, which, as we'll learn, turns out to be one of the key elements of the recipe for a pandemic. The other feature of the virus are the two surface components, the hemagglutinin, which is the H of H1N1, and the neuraminidase, which is the N. These are two components that are responsible for infection of the host cell and also for the release of viruses from host cells to go on and infect other cells within the host. They're important for two other reasons. First of all, it is toward those surface components, and mainly the hemagglutinin, that our immune response, a large part of our protective immune response, is directed. And the second important feature is in line of what I just talked about with the genome being segmented. Both of these surface glycoproteins, and again, particularly the neuraminidase, are very prone to genetic mutation. Essentially, with every replication cycle they're going through, and as they go through populations, it is these two surface components, or the genes coding for them, that mutate pretty much throughout the year and cause this virus to come back in our annual epidemics and allow this virus to stay a step ahead of the vaccine that is prepared the year before. And we're going to talk about both of those, the outcomes of both of those events. There's two types of influenza, and we're really going to be focusing on type A, which is the type that is relevant for pandemic influenza. We do not have pandemics with influenza B. It is a much more well-adapted virus to the human host. Another important feature of Influenza A is it's a natural or zoonotic infection of waterfowl and a variety of bird species throughout the world. And in a sense, humans, for many of the potential subtypes, and there are 16 distinct subtypes of hemagglutinin, 9 distinct subtypes of neuraminidase, for the majority of those, humans would essentially be an accidental host. When you look throughout history, or at least recent history, we've really been affected by only 3 subtypes. The H1N1, the H3N2, and now this H1N1 is the human or seasonal H1N1, and I'll make the distinction a little later on when we talk about the 2009 or swine origin H1N1. The H1N1 and H3N2 have been with us together for about 40 years. Prior, and I'll talk a little about this, we had the H2N2, but beyond those, and we'll talk a little about the H5N1, which is still occurring over in essentially the Eastern Hemisphere. Aside from those subtypes, we've had very little experience with all of these other subtypes, although there is the potential for those novel subtypes to get into the human population. When that happens, and again, I mentioned this before, that is one of the necessary ingredients for a pandemic. We need to have that novel subtype get into the human population. And then within the different subtypes, the H1N1 and the H3N2, we have different strains. And the strains are the result of that constant ongoing mutation of the hemagglutinin neuraminidase that essentially keeps these viruses one step ahead of the population's immunity that's been developed over the previous years. So with that little background, we're going to talk a little about some of the outcomes and review a little some of the features of seasonal influenza, talk about what we thought was going to happen or what pandemic influenza is, how we had planned for it, and then take a look at how the 2009 H1N1 fits into this, and make a brief mention about the avian influenza, the so-called bird flu, or the H5N1 subtype that is still a major concern on the other side of the world, and quite frankly was the virus that all our pandemic planning for the past 5 years had been directed toward, and for good reason that I'll share in a little while. As far as what influenza, there's probably more similarities in this definition for seasonal influenza with the 2009 H1 than there are differences. This audience, I'm sure, is very well aware of what influenza is, a significant respiratory illness characterized by profound systemic effects. At one time or other, we've all had it. A number of us, unfortunately, are probably going to get it again in the near future. A point I want to make, these are the key clinical features. A point I want to make is the characterization that we've heard a lot as 2009 H1N1 is taken off of this being a mild illness. Understand that that statement's made in the context of what could be a worst case scenario with the emergence of a pandemic strain of influenza where one might expect a much more severe disease. So far that hasn't happened. But the individuals being infected with 2009 H1, it's not what I'd characterize as a mild illness. They are being laid out, put into bed for 3 to 5 days, significant fever, and in a growing number of them, significant number of complications. Now, with seasonal flu, and so far it's been the case with 2009 H1, the disease does tend to be self-limited, although in a number of individuals with varying underlying conditions, it can go on to cause much more severe disease, predominantly, or most importantly, primary viral pneumonia, secondary bacterial pneumonia, and we are seeing this occur with the 2009 H1. And another point I'll come back to, particularly since we're kind of in the growing second wave of the pandemic, there's a real challenge for clinicians out there seeing patients because there's a whole raft of other respiratory pathogens that are normally circulate in the community at this time, and I'll talk a little about that toward the end of the talk, because this really does complicate the situation when you're trying to make a clinical diagnosis without the aid of either laboratory testing or epidemiological information. There's some key elements of pathogenesis for influenza, both for seasonal as well as the 2009 H1, characterized by a very short incubation period, very similar between those two viruses. Important to realize that viral shedding, in fact, begins a day or so before the illness actually manifests itself, or the infection manifests itself, and can continue on for at least a week, if not longer, in children in immunocompromised after symptom onset. And when you couple that with the fact that, at least with seasonal influenza, and we're seeing the same pattern emerge now with the 2009 H1, a significant number of individuals can be infected either very mildly or asymptomatically. So you can, with that combination, and then added to the fact that this is a very highly communicable disease by a variety of respiratory means. When you take those together, you can see why influenza is such a successful pathogen in the community and why it's responsible for these often explosive epidemics that we see both seasonally and that we're experiencing now with the 2009 H1. A little about the epidemiology. Back in the simpler day when we were only worrying about seasonal influenza, very predictable. Our influenza season in the temperate climate, northern temperate climate, essentially runs from about November to May. In the southern temperate climate, the reverse during our southern months. Influenza seasons characterized by a very sharp epidemic curve of influenza that occurs in communities throughout the world. You get those initial few cases, very sharp epidemic curve, hits a peak, starts to drop rather rapidly, and then tails off. In recent years, we've had a mixture of both Influenza A and Influenza B, but Influenza A is definitely the more significant illness or infection, in most cases individually and certainly from a public health standpoint. And keep in mind this graph when we go a little later on into the talk. It is absolutely, or was absolutely, a rare event to see influenza during the off-season, during the late spring, summer, early autumn months. And the only time we really would recognize it, despite very extensive surveillance, is associated with travel overseas, often to the southern hemisphere, or to the tropical and subtropical regions where influenza tends to circulate year-round. This is one of the features that is significantly different with the 2009 H1 that we'll talk about a little later. So what's the impact or outcome of seasonal influenza? And we're going to come back a little later on to see specifically what's happened with the 2009 H1, and there are absolutely some very significant differences. Basically with seasonal influenza, and again I'm referring to the H3N2 or the human H1N1, and to a certain extent Influenza B, children really suffer the highest rates of infection, and we're certainly seeing that with the 2009 H1. And then it tails off and is fairly uniform across the age spectrum in terms of who is infected and who has illness that's medically attended illness. When you get to the more severe illnesses characterized by hospitalization, it is the age extremes that suffer the worst effects, and particularly with mortality, 90% of which in seasonal influenza, and this is going back many decades now, 90% of it is in individuals over 65 years of age. You're going to notice when we get a little later on in talk where I show the similar data now with the 2009 H1, this is where the biggest difference is occurring. This isn't happening, and really the 2009 H1 is accurately being characterized as a disease of young people, and you'll see the data to support that. So what's the outcome of this? And I think we've seen these and heard these figures a lot. If nothing else comes from this pandemic, I think we have really raised the awareness of the significant pathogen that seasonal influenza is worldwide each and every year. And when you look at these figures, I'm hard-pressed to come up with any other infectious diseases that have this impact pretty much throughout the world, absolutely each and every year in terms of mortality, morbidity, severe illness, hospitalization, and certainly economic costs. So seasonal influenza absolutely has a huge public health impact. In terms of prevention and treatment, well, I want to go through these slides fairly quickly. I hope most people realize, all people realize, we do have a vaccine, both a live attenuated and an inactivated vaccine, and we are all strongly being encouraged more than ever to get that seasonal vaccine this year. The unfortunate part of this slide is this last point. The fact is, and they've been following this data now for about a decade, the overall rates of usage are extraordinarily disappointing. Really, the best use or the greatest rates of usage are in the highest risk individuals, up around 70–80%. That is the elderly and individuals with underlying conditions. But it drops off dramatically. General populations around 40%. Children, who we really need to target because they're instrumental in the transmission of the virus, as well as suffering a large amount of the disease burden, are under 10–15%. And the really disgraceful, to be honest, rate is healthcare workers and people who are in long-term care facilities and so on barely hit 40%. And they are major disseminators and transmitters of this virus in that type of setting. Hopefully, we're going to gain a little religion here as the result of the H1N1. We do have antivirals, but a disturbing trend over the last few years, and not surprising given the use of the antivirals, is the development of resistance among the seasonal viruses. Basically, the adamantanes now are worthless to be used against H3N2 with complete resistance worldwide. They are still somewhat effective with the H1N1. And our mainstay now, which is enjoying very widespread use with the 2009 H1 over the last couple of years, is essentially, or H1N1, the seasonal H1N1, has essentially developed complete resistance to Tamiflu. Now, zanamivir is still effective, and so far, and I'll touch a little on what we're seeing with the 2009 H1, because we're paying attention to what's been happening all along with the influenza viruses with these antivirals, and we know that particularly Tamiflu and to a lesser extent zanamivir are being used at unprecedented rates, and I suspect it's only a matter of time before we see the level of resistance begin to increase. Because of the public health importance of influenza and because we can do something about it, there is an extensive worldwide surveillance system in place, and actually throughout the world, the United States really leads in terms of the quality and the scope of the surveillance. And within the United States, I think Wisconsin can be very fortunate in the fact that we probably have one of the strongest influenza and respiratory pathogens surveillance programs of any state. And this is very much a partnership between the laboratory and between the Wisconsin Division of Public Health and local health departments throughout the state, with the help of clinicians and clinical laboratories who feed into these surveillance systems. Basically, a laboratory, the State Lab of Hygiene on campus here is the lead laboratory agency in the state taking care of laboratory surveillance. We're looking for novel viruses, monitoring which viruses are present. Right now, 99.9% of the virus present is 2009 H1, but we have other seasonal viruses to worry about which are really going to complicate matters as the season goes on if they reemerge. So we'll be monitoring for that, and then we feed our information to our state and local health departments as well as the CDC, who collates the information from throughout the country to add to the global information. There's also extensive surveillance on outpatient illness, so-called influenza-like illness, temperature of 100 degrees Fahrenheit plus sore throat or cough. Seems very nonspecific, but in terms of being a predictor and an indicator of influenza, it is an excellent monitor of influenza activity, and we'll show you a little of what's happening in recent weeks with the 2009 H1. Very extensive mortality surveillance, now more than ever, because this is the main indicator for the severity of the illness. How many people are being, and hospitalization, how many people are being hospitalized, how many people are dying, and there's several different indicators for both of these. And finally, the overall geographic spread based on a number of epidemiological indicators. What impact is this having on different portions of the country? And again, a little later on, I'll show you the figures where we stand right now. So this takes us to pandemic influenza, and I think it's a fair question, since for most people, the notion of a flu pandemic fell out of the sky, and suddenly not only are we worrying about it, we're experiencing it. And it's a fair question to ask, well, when did we start worrying, or when was the big concern with pandemic influenza? And the fact is, for those of us in public health, those of us particularly who have worked with influenza for a long time, pretty much the duration of our careers. We have a long history through the last century of pandemic influenza. We experienced 3 of them in the last century. The grandmother of them all, the 1918 great influenza pandemic, or Spanish influenza, which now I think everybody has heard through the press and that, claimed upwards of 40 to 50 million lives worldwide, 500,000 or more in the United States within about an 18-month period. And during the succeeding waves, probably infected in excess of 60 to 70% of the global population. That is an incredible number and an incredible event. We lived with strains of H1N1 for a number of years until our second pandemic occurred, the H2N2. Many looking at the age group out here, this was probably a number of our first experience with influenza during the Asian influenza pandemic in 1957. It hung around until 1968, when it was supplanted by the H3N2, which has been with us, strains of it, ever since. And then this is a bit of an anomaly. This H1 virus is related to some of the later ones circulating before they were supplanted by the H2 viruses. It was probably the result of a lab accident. It got out, has been with us in terms of severity, illness, and the impact on the community, much less than the H3N2 over the last 40 or so years. And again, I want to point out, it is a distinctly different virus than the 2009 H1 in many aspects. So we've had a lot of experience with pandemics. Quickly, in terms of some of the models, how these pandemics arose has been studied for a large number of years. Remember, the entire genetic repertoire of possible influenza viruses that can infect humans reside in a variety of waterfowl and avian species throughout the world. It had been known for some time. It's actually a fairly rare event, and usually not successful, for the virus to go directly from birds into humans, although I'll modify that in a second when we talk about what's been happening with the H5 virus. But a preferred model all along had been we get new subtypes because there's a mixture of the existing human subtype, say the H2N2 virus, then reassorting its genetic material with a bird virus, an avian virus, which in that case donated its H3 component and a couple other components. And where it's been thought for many years this was occurring, and extensive lab data as well as field data, in swine, which appeared to be a very good biological mixing vessel because bird viruses didn't readily infect humans, but human viruses readily infect swine and vice versa, and bird viruses readily infect swine and vice versa. So it seemed logical that this could be a mixing vessel. and was the leading hypothesis of where our past pandemic subtypes have come from. You'll see a little later on, it has absolutely been locked down now where the source of the 2009 H1 virus came from, and there is a swine origin involved. What is pandemic influenza? By definition, it results from a novel subtype of influenza, which gets into the population. And since our immune response is really directed in large part to that hemagglutinin and neuraminidase, if you get a real novel hemagglutinin and or neuraminidase, then it stands to reason that the population isn't going to have a good immunity. And that's, one of the necessary ingredients for a pandemic. And then there's a variety of characteristics here that we had been planning for and we could identify from past pandemics. I'll come back to this slide a little later to show how has the 2009 H1 fit this pattern. You'll find out is much of what we thought would occur with the last pandemic, or with the current pandemic, is very similar to what we had predicted, with the exception of it hasn't probably been as severe as we had been planning for. That doesn't mean it's any less disruptive, and we'll talk about that a little further later. In terms of planning, and I've been involved in pandemic planning for about 10 years now, there had been a lot of modeling and a lot of observation of what happened in past pandemics to try to predict what would be the impact in the next pandemic, what did we have to be worrying about. And these figures, I think, are useful because it's kind of a middle-of-the-road number. There are countless models that have been put out there, and in fact, at one end of the spectrum is what if we had a repeat of the 1918 influenza with its staggering mortality and morbidity rates. On the other end of the spectrum, as far as a pandemic event, the H3N2 was not particularly great. Where it really gained its fame is it's been with us for the next 40 years, always drifting and managing to kill 25 or 30,000 or more people each and every year. So its cumulative effect has been huge, but its initial pandemic effect was kind of on the lesser end of the spectrum. For planning purposes, we kind of picked the middle of the road here. And the thing early on in planning, and this is natural, we worried about how many people were going to get sick, how many people were going to get really sick, and how many people would die. And that guided a lot of the planning and is still a basis of some of the key elements of the planning. But over time, we began to recognize that even a relatively minor pandemic could have significant effects and impact, and we absolutely are seeing that now with 2009 H1. I put this up here. This is a slide someone in the Division of Health, the influenza coordinator, Tom Haupt, developed. And it really portrays what we face with the pandemic. These red areas are typical seasonal epidemics of influenza, with about roughly this level of influenza-like illness in a typical flu pandemic. And over the last few years, we've been seeing 7, 8, 10% of the people involved. Notice the peak of a pandemic ILI projection, and then the fact that this is going to occur in waves over a condensed period of time. It's a little inaccurate. What we learned here is our first wave actually occurred last spring into summer, which what we anticipate is going to happen was a little bump right now, well, probably a little bigger than the seasonal before it, but a bump here. But now we're in the second wave, which we anticipate is going to be a much greater wave of illness, and then followed by succeeding other waves, and interspersed there the typical seasonal influenza. So just by the duration that we're going to have to be dealing with this gives an indication this could be a much bigger event, even if a lot of people weren't hospitalized or didn't die. And then this is translating into social infrastructure and economic impacts, and we've already experienced these with schools closures, the impact, the ripple effect that has on mom and dad to provide child care, taking them out of the workplace, or people being excluded from the workplace because they have ILI, trying to get back to work, but there's been a restriction put on when you can get back to work, a certain period of time after you have fever, and so on. When you translate that into our areas of infrastructure, including healthcare, public safety, and so on, and considering we're probably in the very early stages of this next wave, you can see that the impact could be very, very significant. I'm going to digress before we get now and talk a little into pan-flu planning and then what has really happened with 2009 H1. We have been concerned with avian, so-called avian influenza or bird flu, and really we're referring to a particular subtype that emerged in Southeast Asia now over 10 years ago. And periodically there's been enough concern that the concern makes it out into the press. I think most of the concern has been really in public health and in those who really know and follow influenza viruses. But basically what's happened over the last 10 years, this is a virus that normally infected, like all influenza, waterfowl and so on, without any impact. But there was a change in its pathogenicity and there was a change in its ability to transmit to other species. So this virus, if you look at the shaded areas, has had a tremendous impact on not only wild waterfowl, but also domestic poultry. Tens, probably now hundreds of millions of birds have died directly because of the virus or because they were slaughtered to stop the spread and the transmission. More important to humans, in 15 countries, there have been recorded human cases. This is the cumulative number of cases now. Not a large number, but when you look at the mortality rate and the fact that this illness is affecting mainly children and young adults, which is a pattern we're seeing now with a much less pathogenic virus, and certainly was a pattern that was seen in 1918 with that devastating pandemic. This has been a real concern. The saving grace has been virtually all the cases have resulted from direct contact with poultry, and there is no evidence of sustained human-to-human spread. That isn't to say this couldn't happen, and actually we've had heightened surveillance now for this virus in the Western Hemisphere for about 5-6 years, and so far it hasn't been detected, which is a bit of a surprise because it widely affects and circulates in avian species throughout this region of the world, and we know that we're on the same flyways for a number of these birds. So it's really interesting that that hasn't occurred here. It also points out, again, when you talk about a recipe for a pandemic and why we were concerned about this, you need to have a novel subtype of influenza. It needs to cause significant morbidity and mortality. The third, and that certainly has been achieved by H5, the third ingredient, there needs to be evidence of sustained human-to-human spread. That has not occurred with H5. That has occurred with 2009 H1. So the virus we're dealing with now in this pandemic has fulfilled the 3 criteria for a pandemic subtype. So in terms of flu planning, quite frankly, most of our planning for the last few years has been really directed toward what happens when H5 breaks out, makes it to the Western Hemisphere, and gains that capacity to transmit human to human. And that very much is a possibility, either gaining the ability to do it itself or reassorting with the human H1 or the human H3, which is a very successful and well-adapted pathogen in humans. But it hasn't happened yet. 4 or 5 years ago, there's been a lot of planning and concern with pandemic, but it really got serious probably in the last 5 years with the national strategy being developed for pandemic influenza and a variety of planning documents and planning efforts that arose from this, with these 3 main goals. Now, in retrospect, when you look at what happened with 2009 H1, goals 1 and 2 are pretty much out the door because it happened, the first cases were detected and confirmed in the United States. The event that led to them getting here occurred just across our border. So there was little or no chance at slowing the spread when this occurred in April. But fortunately, most of the planning efforts had been placed in sustaining infrastructure and mitigating the impacts that a pandemic strain could have. And we really are reaping the benefits of that as we deal with 2009 H1, and we'll talk about that a little later. The real guts of the plans in all of our states is actually found in this document, which is the strategy for community mitigation. Basically, we knew that when a pandemic would occur, there's going to be a period of 4, 5, 6 or longer months where we weren't going to have a vaccine, and there was some question whether we'd have enough antivirals. We've had enough antivirals. I think we're all aware of the vaccine issues here that I'll touch on a little later. So we had to rely on a number of other strategies, and we should be familiar with most of these now because this is all we've got. Self-isolation, possibly self-quarantine if we have individuals in our family who are confirmed with having a pandemic strain, school closures, business closures, enforce getting people out of the workplace if they're sick, and then supplementing this with just basic personal hygiene. We recognized this was going to be the core of response, and we got it right on a national and, in fact, international basis. Okay, I don't know why it's doing that. Every state 3-4 years ago had to put together their own pandemic plans. These are the key elements. You can access it both at the National Pandemic Flu, that website I just showed up there, and also at the state's website that I'll show you in a few minutes. But all the elements that would have to be dealt with in dealing with the pandemic, there are written plans put in place. And the one obviously I've been involved with is in surveillance and laboratory, communication, antiviral stockpile, mass vaccination. These are all the relevant ones right now. And there are plans for all these other elements. Whether they're being used or will be used or not depends on how severe the situation is going to get. That takes us into what's happening with the H1N1 now. 2 key resources, and this is going to be available to you. The cdc.gov H1N1 resource is absolutely the best place to go for healthcare professionals, for general public, for anybody. And to translate that information to the state level, what we're doing in the state and what's happening in the state, you go to the pandemic.wisconsin.gov. All the information, this information is updated essentially daily, and one of the real high points of the response so far has been the communication and the information sharing that's been going on throughout the public and private sectors, and in partnership or with partnerships between the public and private sectors to get the information out there. Now, we don't always like the message being delivered to us, but it's getting out there in a very, very timely fashion. I just want to come back and remember the model here and go through a series of slides of what has happened. What do we know now since those events in the middle of April? It really looks like what most people felt who work with influenza, that swine were a key player here. And an interesting set of events was occurring starting back even earlier in the last century, when that H1N1, which caused all the havoc in humans, a cousin of it got into the swine population many decades ago and developed a stable relationship with that population. And then our H1N1 developed its own relationship with the human population. We'd recognized about 10 years ago there was a situation arising where the swine H1N1, which legitimately was a swine H1N1 virus, was reassorting with a human virus and a bird virus and affecting or infecting individuals. Didn't transmit person to person, but you can go back now in studies over the last 10 years, including some cases in Wisconsin, where this cross-species infection did occur. And we were monitoring this. Well, the big event occurred where another lineage of the swine virus from Europe mixed up with that triple reassortant to give us what is now a quadruple reassortant, and it was really that event that gave this virus the capability to transmit human to human. There's a lot of work going on. Where did this happen? Exactly when did this happen? What were the circumstances that caused this to happen? And that's kind of all going on in the backgrounds here as we deal with the effects of that event. Another thing, and this goes back to a point I made and kind of being directly involved in this went way, way quicker than anybody involved in planning anticipated. You always had in the back of your mind, well, maybe a pandemic could arise in our country, but you tend to plan for a more worst case scenario or a manageable scenario. The fact is the first confirmed cases were identified or announced on April 15th, and in a little over 2 months, we declared a global pandemic. And that is just amazing how quickly that happened. And most of the key events probably happened within the first 2 or 3 weeks, with the public health emergencies being declared in the United States and in Wisconsin, and our response efforts going off the chart. So this notion that we were going to have weeks or maybe months to kind of get our act in order here just never materialized. So basically anybody dealing with this, both in public health and clinicians and laboratorians and everybody, has been dealing with this under the gun essentially from day one. There was no time to really prepare for much. It just emphasizes what happened. Here was our nice, real calm seasonal influenza curves. And actually last year, we do monitor and we have a large annual kind of history of influenza. Last year really was a so-so ho-hum year as far as influenza. We were just coming out of it when April 15th hit, and then the fun began with the spike here. And then the more notable part of this, I go back to that early graph that I showed, is influenza did not go anywhere this summer, and we're now on the upward swing of the second wave. This is unprecedented in anything other than history textbooks. Certainly all the generations represented in this room, this is the first time this is happening, and we're having to respond to this. It's really quite an amazing event. Let's look a little at the clinical presentation. A lot of similarities I mentioned, but very notable, the increase in gastrointestinal symptoms in 20 to 30% of the cases across the age range. I've been talking about influenza and talking to clinicians for 25, 30 years, telling them, no, flu isn't vomiting and diarrhea. Flu is a respiratory illness. It took a few decades, but I was proved wrong, I guess. So, fact is, it is a significant component of this infection. I say the illnesses are milder than we planned for. Again, I go back to that point I made. We were thinking you're planning against worst case in terms of morbidity and mortality. So far, a lot of the illnesses are mild. The vast majority are. But in a significant number, in a growing number, and particularly of younger individuals, it is a very severe and often fulminant respiratory disease here. And in some cases is resisting any attempts of intensive care and antiviral usage. So this is something to pay close attention to. Although the numbers aren't huge, the impact on the individuals affected with more severe disease are huge. Often they have underlying conditions. In somewhere around 20%, that's not the case. They're otherwise healthy children and adults. Pregnant women are particularly targeted here, and that's no revelation. Flu has always been a bad illness in a pregnant woman. This is no exception, but fortunately there's a lot of attention being directed to that population. It is difficult to distinguish influenza from other respiratory viruses, and in a little monitoring we're doing, we've really gotten into the epidemic phase in the last couple weeks here. But going back a few weeks, from the perceptions of the clinicians and a lot of other people, there were a lot of sick people out there. And this just shows we do monitoring for a variety of other respiratory pathogens. We are dealing with a lot of rhinoviruses and parainfluenza. This is the season they normally circulate. They normally affect a broad age range, and particularly the most severe illness, again, being in the very young and in children. So in many cases, people presenting to their healthcare providers probably didn't have influenza. And this is going to continue for a couple months now. Keeping in mind in any given case, particularly with a novel virus, a good indicator of influenza is the systemic nature, the profound myalgia, malaise, and most importantly, fever is probably the best differentiator between some of these other respiratory illnesses, which at least in older populations, it's very rare to have fever or any substantial fever with most of those other viruses. Does it fit our pandemic definition? I showed it to you before. The big divergence here is we were preparing for something that made a lot of us sick, made a lot of us very sick, and then killed a lot of us. That hasn't happened, and interestingly, that's had a kind of an odd effect in terms of people, their perception of the seriousness of this. And I get a sense that, well, we could make everybody happy and have whole lots of people hospitalized and die there, and then we get the pandemic we want. Fact is, this has been a little inhibitory, and it probably led to the World Health Organization really dragging their feet for a couple weeks before they declared this a pandemic. People just weren't that sick, and we really hadn't prepared for that eventuality. And so we ought to count our blessings, but the bad news is this could change. This is a very changeable virus, and we have to be aware that that could change dramatically. Just a couple graphs here to show you data from CDC, and they're roughly comparable to that earlier one, the impact of influenza across the age range. This is very similar to what you see with seasonal influenza, keeping in mind we've condensed a number of the age groups there that are in that first graph. But definitely it's focusing on children and young adults, and probably a little more on young adults than seasonal influenza does. Definitely children are being hit, but that happens all the time. Here's where the differences are. In terms of hospitalization, definitely focusing on these age groups, relatively sparing those greater than 65, but a significant number of them are still ending up with fairly severe illness. The real dramatic difference is in the mortality, and although the mortality is only in the hundreds, maybe low thousands only, this peak is very disturbing in that the targeted groups are children and young to middle-aged adults, and a very profound sparing of the elderly who normally suffer 90% of the mortality with seasonal influenza. And this has been seen before in other pandemics and is a cause for concern. So where are we today? There was a big issue, and you can go back to that graph I showed before where there were lots of numbers. Wisconsin led the league in the number of cases identified. Not because we got hit worse than anybody, but the fact is that's more of a reflection on the flu surveillance we have in place and the very aggressive approach that the Division of Health took in monitoring what was going on. We wanted to identify as many cases as we could. That has transitioned this summer throughout the country to go back to our traditional flu surveillance systems that I outlined in that earlier slide, and that's where we are now. If you go to that website, the H1N1, CDC H1N1 website, weekly they have the Flu View, that weekly report on influenza, what's happening in the US. The series of slides that follows is just lifted from last Friday's. The entire country, virtually the entire country, is experiencing widespread influenza, which absolutely is unprecedented considering we're in the third week of October. We don't see a map like this normally until the end of January or February. And I would imagine we'll probably still see this map then if this comes back as a second wave or we have seasonal influenza to worry about. Influenza-like illness is now on a very steep upward curve. Hospitalization and deaths across all age groups, and particularly in pediatric populations, are on a sharp increase. Again, much earlier than we would typically see in seasonal influenza. And these numbers in the pediatrics are becoming much greater than we typically see. To add a little context, though, these are other data from the Division of Health that they update weekly. These are the number of laboratory, essentially confirmed and probable cases. It's still relatively mild in terms of the number being hospitalized and dying. The red are the hospitalized. The vast majority of infections run their course and all is well. So we need to keep that perspective, but there's a lot of surveillance looking at the hospitalized and death to make sure that we don't see a dramatic increase there, which obviously would be a bad outcome. The vaccine, I just put this on there. This is the information. Go to the CDC website if you want information about the vaccine. They started producing this a couple months ago. In earnest, we knew back in April or May, once we were able to start the vaccination development of vaccine, it could take 4 to 6 months. CDC said it. It's where our technology is. And unfortunately, that's coming true. Again, I also refer you to the wisconsin.gov, pandemic.wisconsin.gov, for updated information in Wisconsin. The interesting thing happening here now is our judgment in real time. And I bristle a little at this as a public health worker. The effort in the last 6 months across public and clinical health is nothing short of heroic. The undertaking to try to develop and get this vaccine out to essentially the entire population of the United States, not to mention the rest of the world, is beyond comprehension when you know and analyze the steps involved. But there have been hiccups here. The feds were left with a tough decision. They're producing the vaccine. Do they wait until they have 100 million doses and then send it out? Or do they trickle it out as they can develop it and start making some people, providing protection to some people? They chose the latter. They're paying a price for it here because there have been bumps in the road. But the logistics involved here are absolutely incredible. Antiviral effectiveness so far, just to make it short, because I got a couple other points I want to make. There have been sporadic cases of resistance to Tamiflu throughout the world. It has not appeared to be on the upswing here or transmitting from human to human. So that's good news. State Lab is one of 2 other labs who are serving as regional surveillance centers for antiviral resistance, working with CDC. So we're going to get a good firsthand picture of what's happening in the country, and those efforts have just started in the past week. We're back to right now, until the vaccine's out there, this is how we prevent it. Basically, judicious use of school closure, keeping yourself at home when you're not feeling well, so on and so forth. Speaker accepted here. So. Just did our plans work? I love this quotation and in its various forms. I would say any of us who've been involved in planning, I have a shelf full of plans this big, which to me was always kind of a foolish endeavor. Going through April, May, June, at no time did I go to any one of the plans I had been involved in. But in the planning, I know who I communicated with. I knew what we were going to do. And the effort that has gone in, and I think the success of the effort to limit the situation so far has been remarkable. Starting from when the CDC got us out the specific diagnostic test within 2 weeks of the first identifications, private sector labs getting involved in the testing and plugging their data into public health, the communication that's gone across all sectors, and really hats off to the CDC and our State Division of Health and how they share information on a day-to-day basis. It's there, and we may not like the message always, but that information is there for us to use. So, the plans didn't do me a lot of good, but I thank God the country did spend a lot of time over the last 5-10 years getting ready for this. As far as tomorrow, we learned a lot this summer because influenza made its venture through the southern hemisphere. Like I mentioned that it does, and now it's coming back at us. So far, it has not changed itself. It hasn't mutated, so the vaccine that was developed should still be good. That could change, however. The clinical presentation, its epidemiological characteristics have not changed so far, 6 months into the pandemic. That's great news. Again, that isn't to say that couldn't happen. Big concern, a number of the countries here have H3 still co-circulating. If I could deal just with the 2009 H1, my life would be a lot easier, as would yours as clinicians. If H3 comes back as the seasonal flu, it's got a different target population for the most severe effects of the disease. There are different antiviral issues, and the fact that there is a growing body of data that that virus is drifting over here. It could come back here and that seasonal component of the vaccine not be optimal. So, and we're monitoring this. This promises to be very interesting next few months. Finally, should we be concerned? Yeah, shouldn't necessarily be scared, but why we should be concerned? We're in a pandemic. Typical flu season, you have 8 to 10% in a relatively bad year. We have to be prepared that up to 40% in the waves in a different locale could be affected. And this goes way, way beyond what we see in seasonal influenza. The virus has that huge potential for change, and we've got to be aware of that. Just because it hasn't doesn't mean it won't. And understand, the longer it circulates in the human population, there's a huge immunologic pressure for it to change. This is what influenza does. And I would anticipate the same is going to be with the H1. We are now finding, we're barely a week into the typical influenza season. It really doesn't fire up until November and December, and we're already into what would typically be a big-time epidemic in a normal season. So it waits to see how bad is it going to get this season. We worry about the co-circulation, not only because of H3N2 is a bad virus in its own right and really targets the elderly. We're going to have that, the real potential that this could start mixing and matching its components with the 2009 H1, which generally would not be a good outcome. Keeping an eye on the age predilection and illness severity, the children and young adults are really bearing the brunt here, and we really need to be focusing and kind of restructuring our thinking, because many people really consider this to be a problem typically of the elderly and those with underlying conditions only. And finally, we'll see what happens here when we finally do get the vaccine. Are we going to be able to damp down the succeeding waves? Is this going to drive the virus to change that much quicker? We don't know. We'll look for it and stay tuned. So with that, we've got a few minutes. I'll hang around if anybody has any questions.